Now, coming to CT coronary angiography, there are numerous indications, right, from bypass grafts to coronary anomalies to vascular anomalies, etc. But in the setting of screening, ruling out significant luminal stenosis in a stable patient with suspected coronary stenosis, but with an intermediate risk of likelihood of a pretest probability of having a obstructive coronary disease. And when you have an atypical chest pain in an individual who has got a low or intermediate risk of coronary artery disease on the pretest probability, then also you could do a CT coronary angiogram. But the current role or a lot of interest is there in evaluation of the plaque characterization, as well as the whole plaque burden. These are the work in progress, especially the plaque volume. So you obtain the density of the plaque in terms of quantifying or qualifying it, whether it's a low attenuation plaque, which is minus 30 to 30 Hounsfield units. You measure the density of the plaque. And we have a plaque which is minus 32 or less than 30 HU is called as a low attenuation plaque. You have a fibrofatty plaque, you have a fibrous plaque, and a dense calcified plaque which has got a calcium of more than 350 HU. The whole idea of assessing the plaque is to look at features which could qualify it as a high risk plaque, previously called as a vulnerable plaque. So we have high risk plaque features of low attenuation here. So we have features of low attenuation plaque here, a plaque which has got less than 30 HU in density, a calcium which is spotty in nature, such as this, or a positive remodeling where the arterial diameter is more than 10% of the adjacent normal artery, or you got a napkin-ring sign which is a crescentic area of a low density or a necrotic lipid core with a thin wall. So if you got any of these four features, this implies that it's a high-risk plaque. Of these four, a low attenuation plaque or a napkin ring sign are more likely suggestive of a high-risk plaque, which is likely to result in an acute coronary event. Now, when do you screen asymptomatic individuals with coronary angiography? There are two studies which say that the Swedish trial in asymptomatic patients where they performed a CT coronary angio in the community setting. So what they have found that is in patients with a calcium score of 0 even, there was increased risk of having arrhythmias disease in diabetes and patients with a strong history of MI up to the tune of 6 to 8%. And the Factor 64 trial, which only randomized controlled trial in asymptomatic patients with diabetes who underwent coronary angio and the standard care of testing. Again, they found that the CT angiogram study showed a 20% risk of having major cardiac events, though this was not of statistical significance. The two trials which are work in progress, the Scott Hart trial with 6,000 asymptomatic individuals comparing the CAD risk, and the Transform trial, especially in asymptomatic pre-diabetics, diabetics, and metabolic syndrome. So these two trials will tell us what would be the role of CT angiography in the asymptomatic patients. Now, contraindications are there for CT coronary angio. You have an acute chest pain with high probability of coronary artery disease. They don't come for CT coronary angio. They go straight for an invasive catheter angiogram. Evaluation of coronary stents less than 3 mm, it's not good enough. Poor renal function, contrast allergy, and pregnant females. These are, again, contraindications for performing a CT coronary. One significant limitation of CT coronary would be in patients who can't hold their breath or who have got severe arrhythmias, where you don't get good angiogram-like pictures. And severely calcified vessels is again a poor, the sensitivity of the test would be less. So comparisons, a catheter angiogram and a CT coronary angiogram showing a critical LAD ostial stenosis. Again, a cath and a CT angiogram correlation showing significant ostial stenosis of the LAD. And this is a diffuse RCA disease, which shows that there is extensive calcification in the artery. And this could be a major limitation of exactly identifying. You can see that the CT angio under-reports the extent of stenosis, whereas the catheter angio shows the luminal narrowing much more in detail. So a calcium score more than 400 would not recommend doing a CT coronary angiogram. Instead, it's better you perform a catheter angiogram. So future directions, especially with artificial intelligence, volumetric measurements of the atherosclerotic plaque is one area of interest. Detection of high-risk plaque features, and delineation of pericoronary adipose tissue, which is a soft biomarker for coronary artery inflammation. These are work in progress, especially with the utilization of artificial intelligence. The other important thing is about the physiological significance of lesions, what you do as a fractional flow reserve at your coronary CT. There are fluid computational models, dynamic models, where you could do it at CT as well, but it's more tedious and expensive. Myocardial CT perfusion and endothelial shear stress are also being performed using the 3D fluid dynamic computational models. And photon-counting CT can depict the smaller arteries much better, and it can show the contrast and the luminal stenosis much better than a currently available multi-detector row CTs. But it's pretty expensive. It costs over 45 crores. I don't think it's there in India as yet. So these are my references, and thank you so much for your patient hearing.